Thanks everybody for coming. This is the fourth session of 12. So far I've been sitting in the back instead of up front, but my name is Margaret and I'm part of the research team. I work here at the University of Manitoba, and that purple swirl, which you'll see when the slide is visible again, is the center where I have my day job. What we do at our center is help provide information to healthcare providers, public health and government about HIV and DDI. And so really happy to be part of this project too. Today we have Dr. Laurie Ireland with us. And thank you, Laurie, for coming. We're working our way in a progression of information. And today she's going to talk about HIV, transmission prevention and control, which Dr. Kamen last week did not talk about. He talked about his favorite syphilis. Dr. Ireland did her medical training here at the University of Manitoba and graduated in 2005, and then did family medicine practice training in 2007 at St. Paul's Hospital, which is in Vancouver. After that, she did further training on HIV under the supervision of the BC Centre of Excellence for HIV/AIDS, which is world renowned. And then we are very glad that she has come back to Manitoba, or returned to Manitoba, to work at Nine Circles, where she's the medical director and primary care lead with the Manitoba HIV program. I know everybody's familiar with. So like last time, we're going to start with that does get you a thumbs up. We're going to start with the what's called the pre-test. This is just, what's our general knowledge. Dr. Ireland's going to speak, then how did she do? How did we do in presenting the information that we need? And that helps us with figuring out how we're doing. So same as every time. This way we can tell funders, learning happened, people found it was useful. So that's why we do this. We'll just take a couple of minutes. There you go. Everybody online getting it, Mariana? Yes. Thank you. Okay, we'll just take a couple of minutes and then I'll gather these up for you. And I can select any that are. Get another touch. Definitely can do the start and see what you can use.
I know, right? You're welcome.
You want to start it? Okay. We're doing online.
No? Okay.
Okay, well, okay. I can get them from folks when they're ready, so. Lori, I'll turn it over to you.
Thank you. Thanks so much for having me here. Can everybody hear me okay? Can you hear me now?
Is your speaker?
No. Is it on? It sounds a bit quiet.
Yeah.
Is it on? You can hear me now.
Yes.
Yeah.
Yeah.
Thanks so much for having me. I recognize some familiar faces, but I thought for the sake of time, we'll get everyone to introduce themselves. I think you all had the opportunity to meet each other. I'm Lori. That I'm a family physician. I work at 9 Circles, which is part of the HIV program. This course has received some funding from a pharmaceutical company, Gilead, but I have not personally received any financial support and have no conflicts of interest there. The University of Manitoba is located on the original lands of the Anishinaabe Cree, Oji Cree, Dakota, and Dene peoples, and it is the homeland of the Métis Nation. We respect the treaties that were made on these territories, acknowledge the harms and mistakes of the past, and dedicate ourselves to move forward in a partnership with Indigenous communities in the spirit of reconciliation and collaboration. Today, we're going to talk about HIV, transmission, testing, prevention, and treatment. I didn't start with any sort of statistics, but just people know there's maybe about 38 million people living with HIV around the world, about 70,000 in Canada, and Manitoba has the second highest rates of new infection in Canada, with unfortunately the ongoing increased rates that this sort of research team is aware of. That I'd like to thank everyone coming out and participating to really understand better what we're seeing, we're seeing it address the pandemic of HIV and other issues going on in Manitoba. So what is HIV?
So it's one of the
Yeah.
Can we switch to the?
Oh, yeah, I was gonna say,
gallery?
I'm seeing this too, I think
Yeah.
I can minimize it.
There we go.
Yeah. We can also, we hide this, I don't know why it starts open again. Like this. Turn this off. You should do it now, right?
Thank you.
Perfect.
How many meetings I mean, I don't have to do that.
And you're
Hide it, I mean,
welcome
appear
to
it-
interrupt me and ask questions along the way. And so HIV is a virus. It's actually called a retrovirus because it has RNA on the inside, unlike our cells with DNA that it just has RNA copies inside itself. It infects our CD4 cells. CD4 cells are part of the body's immune system. So
What does RNA stand for?
that's a really good question, and I actually had to make sure I knew that. It's ribonucleic acid. So it doesn't tell a cell sort of what to do. It needs to move to become DNA to be able to sort of live on its own. So HIV needs to, because it just has that RNA, needs to get inside another sort of living thing like a human to be able to live and use our DNA. So when it gets inside a human body, it's looking for a CD4 cell. CD4 cells direct and coordinate our immune system, and our immune system is what we use to fight off and prevent infections. Also, to some extent, they prevent some cancers. So over time, if we get infected with HIV and aren't on treatment, the number of CD4 cells in the body decreases, and we lose our ability to fight infections. We get things that are called opportunistic infections because they take the opportunity to get sick when our immune system is weak, and that can eventually lead to death.
I don't know, well, I'm just curious.
Yeah.
Could HIV live in animals too, if they're living? Like,
It's a different type of virus.
Oh,
So
really?
it mutates a little bit to be living in other animals. with another animal.
Oh,
There's a similar, like cats have SIV, I think it's called, but
oh,
I don't know that much about it. That's more. like
okay.
basic science. Yeah.
Oh,
So this is just sort of an animated picture of HIV showing you that they've got,
What is that, and
so that's what they have in the center of the cell. They're called RNA. It also has a little something called the P24. I noted at the bottom.
Yeah.
That's what, when you get an HIV test, that's what we're looking for in the blood to see if there's that little protein that's on HIV. This is a really complicated slide, but I just put it up there to sort of give you an idea of what happens when HIV enters the body. It looks for that CD4 cell. It binds with the cell, gets inside. It makes the RNA into DNA and gets right into our own cell's DNA. Then it takes over that cell and uses everything inside it to make more HIV. So when it goes through this life cycle, the CD4 cells are destroyed, and the number of CD4 cells eventually declines in the body. The amount of HIV that's in the body that gets into the bloodstream is called the HIV viral load. So
I've got a
without,
question about the
Yeah.
DNA. If a woman that's pregnant has HIV, and I know if you're on your medication, then the child cannot get HIV.
right.
But with the DNA, does that make any difference on a pregnancy, or is it just the cells that
Yeah, so if you're on treatment, the HIV in your body won't pass to HIV in a baby because it's not in your bloodstream.
okay,
Treatment prevents that. So that, yeah, the amount of HIV in the blood is called the HIV. So if you don't have treatment, HIV goes through some stages. The first or acute stage, sometimes people call it seroconversion, may feel like a flu, or you might get a sore throat, maybe cold-like symptoms, maybe a rash. That might resolve over a week or two, and then people usually feel no symptoms. In that chronic stage, some people call it a latent stage, that can last for years. And then eventually, people may get sick with HIV. That could be called a late stage or advanced HIV, sometimes referred to then as AIDS. So AIDS means an acquired immune deficiency syndrome. That's when someone has had HIV so long that it's now their CD4 counts drop to less than 200. That's when people are more likely to maybe experience symptoms, maybe have infections like yeast infections in the mouth or other infections.
could internal bleeding cause HIV?
So only if the bleeding came into contact with someone else's blood or fluids. So we'll talk a little bit more about sort of those risks for transmission.
For those online, could you try to repeat the question with your
Oh, okay.
Because sometimes.
Yeah, sorry.
They just kind of hear, oh, good.
So the question was, if you had internal bleeding, can that pose a risk for HIV transmission? So only if the bleeding got into contact with someone else who didn't have HIV, and in a fluid that can actually get HIV. Go ahead.
What's internal bleeding?
So if maybe the question was what's internal bleeding, so I think the question was probably around like if you had, sometimes if you have a sore and ulcer in your stomach can bleed, or if you have hemorrhoids, they can bleed. The question is whether or not that can lead to transmission. So if someone else is exposed to those fluids, either in their genital fluids or directly in their blood, then that could pose a risk for transmission. Well, this slide just really speaks to the same thing about stages. The blue line is someone's CD4 count. So without HIV, a normal, or with HIV, a normal CD4 count is between 500 and 1500. That you can see with that blue line, when someone's first infected, it drops, then it comes back up, and then it usually takes years to decline. The red line is an HIV viral load. When someone's first infected, the viral load is usually really high, that's where there might be lots of transmission because there's lots of HIV around and someone might not know they have HIV. Usually if someone knows they have HIV, they do things to protect their partners and prevent transmission. Then that viral load might come down a little bit and even without treatment, but doesn't go down to undetectable levels like it does on treatment. And that might stay the same for years until late stages. Again, at late stages, HIV viral loads will be high, and that's also where we might see high risk for transmission. Also at that late stages when people might experience symptoms where maybe they have some weight loss or fevers or night sweats or get other infections related to HIV. So these are the fluids that HIV can spread through. Blood, semen, rectal fluids, vaginal fluids, and sometimes through breast milk. HIV can only be passed on when the virus in one of these fluids gets into the bloodstream of someone without HIV, and that can happen through broken skin, through the opening of the penis or wet linings of the body. So that's like the vagina or the rectum or the foreskin on the penis. Those are areas where if exposed to blood or fluids that contain HIV, only these fluids that HIV transmission can take place. Go ahead.
Well, this is a few years, well, I know, a few years back, maybe about 7, 8 years. You're in this Moments program and we were told there that you can't pass because there was one of the girls was nursing and they were told that you can't pass HIV like that. If she was
So the
nursing.
risk is actually pretty low. There is still some risk, especially if, I don't know if anyone's ever seen or breastfeeding, but you can get like broken skin on the nipples where maybe then there's some bleeding. And that could maybe pose the risk.
Oh, yeah.
So we can't know for sure that there's no risk. So we say the safest thing is not to breastfeed if someone's living with HIV. And fortunately, the HIV program has the support program that pays for formula.
Okay.
So for living with HIV, formula feed instead of nursing. So just because someone's exposed to fluids that contain HIV, there's not always transmission. The risk actually, every one time someone might is exposed might not be that high. HIV needs to find the CD4 cells to cause transmission. There's another question.
Do males, once they catch it, do they experience in the same way as a female catches it, like with all that discharge? Does the male go through that same discharge also?
So the question was around when someone's first infected with HIV, do men and women experience the same symptoms? So I think even between the same gender or transgender or men or women, the symptoms can be very individual. Some people will feel no symptoms when they're first infected. Vaginal discharge may not be maybe a symptom and maybe related to potentially other sexually transmitted infections. And then the symptoms that people experience can be different and maybe even none at all. So the risk for transmission varies widely based on what kind of exposure you've had or other factors. But most commonly it takes place after exposure through unprotected sex or sharing meals or other drug use. These are definitely ways that HIV cannot be transmitted. So sharing dishes, mosquito bites, hugging, kissing, sharing toilet seats, through the air, shaking hands, exposure to sweat, tears, or saliva. Those are not ways that HIV can be. There are factors that do increase the risk. I had mentioned like early in infection or late in infection, you might see high viral loads, and that might increase the risk for transmission if someone's very exposed. And then certain types of sexual activity carry a higher risk. Unprotected anal receptive sex is higher risk than other sexual activities. And then if you had another sexually transmitted infection when you were exposed or the person with HIV had a sexually transmitted infection at the time of exposure, that also increases the risk for transmitting HIV. But fortunately, there's lots of ways that we can decrease the risk for transmission or prevent HIV. So I will go through in the next slides all these things separately, but getting tested regularly, using condoms, using new needles or other drug use supply. There's something called pre-exposure prophylaxis, which is medication to prevent HIV, or post-exposure prophylaxis, which is medication taken after potential exposure to HIV, and HIV treatment itself will prevent onward transmission of HIV. So the first thing I meant to mention there is just routine testing. So just by going to get tested, that provides the opportunity to detect other infections. So things like gonorrhea, chlamydia, herpes, syphilis, those things, if you have that infection, can increase your risk to get HIV. So just diagnosing it early and treating it decreases your risk. And it also provides the opportunity to talk about HIV or provide some making sure you have access to other preventative strategies just by coming for testing. Routine testing for HIV also decreases the risk for HIV, and it gives people the opportunity to connect to care and treatment that will prevent disease progression, prevent HIV from getting worse, and also prevents onward transmission if someone's on treatment. So the Manitoba HIV program has recommendations for testing and suggests that everyone, regardless of any sort of risk for HIV, gets tested every 5 years. Then if there's increased risk, people who will have a belong to a population that might have a higher rate of HIV, so that includes men who have sex with men, that's inclusive of transgender individuals, people who inject drugs, or people with multiple sex partners might have a higher risk, so should recommend get tested more often, at least annually. And then if someone's over 70 and never had an HIV test, they should be tested at least once. So this is, I just noticed, I don't know if you're seeing the title at the top there. Can you see my whole slide? No, I think it's okay, but this slide is about HIV testing and the different options for testing. The most common way to get tested for HIV is with a venous blood sample, so a needle in the arm to take a blood sample. That's what gets done in our provincial lab at Chatham Lab. It's called a fourth generation test, because there's been different kinds of HIV tests over years. So every HIV test that gets done has something called a window period, and that's just the gap between when someone's first infected and when you'll get a positive HIV test. So for the standard test that goes to the lab, that gap is just 2 weeks. It can be longer, but usually we're able to pick up a new HIV infection within 2 to 3 weeks of that infection having been acquired. It can, though, sometimes, because the test is looking both for a marker on the HIV virus, that's that p24 protein, and also looking for antibodies that we develop in our own bodies. So you need both things to get a confirmed test. So sometimes that antibody takes a while to be formed, so the window period can be up to 12 weeks, but usually we've picked it up within 2 to 4 weeks.
I was tested, again, which I didn't know I was being tested, but, at the, Misericordia Hospital, and they gave me the results like that. I went to the hospital in the morning, and then I got out this in the evening, and then they gave me, a little card, about 9 circles. And that was it, like, that's all they told me, but, I got my results right away, and they told me I was positive. That was about 20 years ago.
So there's just comments about having been tested at the hospital here and being able to get tests. You didn't know you were tested.
No, I did, this is at Misericordia, yeah,
At Misericordia
Yeah.
Center, and getting the test results right away.
yeah, I got them right away.
I'm not sure what kind of test that was. We do rapid tests,
Or,
that they usually need to be confirmed with the standard test. We'll talk a little bit about that too. The standard test usually gets results back within 2 weeks.
We have a question online from Jacqueline.
Okay.
She's asking, is there a way to pinpoint sample transition?
The time of transition?
Pinpoint
No.
of time of transition.
No. That's a good question. You may be able to estimate just if we've had a negative test, but it's not specific. And especially that's one of those things that is really great if people have gone for regular testing, we know that if you had a negative test 1 month and then sometimes they'll call the test indeterminate if they just have that marker on the HIV virus seems to be positive, but there's no antibodies yet, and that signals you to get repeat testing quickly. But yeah, that's the only way so that we can gauge how long the infection has been there. Sometimes you can gauge looking at the CD4 count to know that it's likely been long, or years maybe, if there's a low CD4 count at the time of diagnosis. This test takes about 2 weeks to come back from the lab. The other types of testing are point of care HIV tests or an in-sea HIV self-test. The point of care test is done by a provider. It's a little finger poke. There's a picture of it there. And it takes just a few minutes to develop. It looks just for antibodies that people develop in response to being infected, in response to being infected with HIV. So that it has a little bit longer window period. So usually it's positive after 4 weeks of infection and maybe as long as 12 weeks. We actually call the positive reactive because it's not a confirmed. Well, it's very rare to get false negatives or a negative test a positive when there's not HIV there. It can happen. So we always need to confirm with the standard test that goes to the lab. Okay. So I ask questions if that doesn't, but basically if you get it would call a reactive test, it likely means there's HIV there. There's only 1 or 2% chance that it's not HIV, but it always needs to be confirmed with the standard test that goes to our lab. Same with the INSTI self-test. These are newer tests available in Canada now, and some in Manitoba. You can get them at 9 Circles. This is where you can go away with the test and do it yourself, also a finger poke test. Similarly, the window period is the same, which is between 4 and 12 weeks, and also needs to be confirmed with the standard. Other ways to prevent HIV are using condoms that prevents HIV. Also, making sure people who inject drugs have access to needles or syringes, other drug use equipment. So if you're able to use new supplies every time, that decreases the risk that people could be exposed to HIV, also to hepatitis C. Also, opiate agonist therapy. So that's treatment like Suboxone or methadone for people who use opiates like down or fentanyl. Getting on those treatments allows people to decrease or discontinue injecting drugs. So that can be a way that some people decrease their risk. And then there's something called PrEP. So PrEP is short for pre-exposure prophylaxis. So it's the use of 2 medications that come together in a combined pill, 1 pill once a day, that is taken every day for people who may be at high risk of getting HIV, will decrease the risk, and it's highly effective if we're able to take the pill every day at preventing HIV. So who's eligible for PrEP? If people are HIV negative and at high risk in the following in these categories, if they're gay or bisexual, transgender, men who sex with men, inclusive of transgender or gender diverse people, some heterosexual people if they're at high risk, for people who inject drugs. So if we look specifically, this gets a little bit more detail, but specifically at some of those categories for men who have sex with men, if they're HIV negative, they practice anal sex, have other sexually transmitted infections recently have had HIV exposures that required what's called post-exposure prophylaxis. I'll talk a little bit more about that after this slide, or if they have a sexual partner that has HIV and isn't undetectable. So if their viral load is up and they have a sexual partner that doesn't have HIV and wants to be on medication to prevent, they might be eligible. In the heterosexual population, if you're HIV negative but have vaginal or anal sex with a partner that's living with HIV who has a detectable viral load, or someone who has frequent sexually transmitted infections, that might be increasing the risk for transmission. They could potentially take PrEP or medication.
What if your U equals U though? You still have to take PrEP?
So the question is, what if your U equals U? So undetectable equals untransmittable. So if you're on treatment and have an undetectable viral load and your partner doesn't have HIV, there's no risk for transmission. So there wouldn't be a recommendation to go on PrEP. There's no need for that partner to be on PrEP. And then for people who inject drugs, if they're sharing drug use equipment and are HIV negative, they'd also be eligible.
Are there any side effects of using PrEP? If
So-
you're using it for prevention?
Yeah, so the side effects, I mean, there can be some medication side effects. Generally speaking, it's tolerated pretty well. Maybe you might get a little bit of nausea or stomach upset when you start, but usually that goes away. The main risks of the drug that's used for PrEP is potential to hurt kidneys. It's pretty rare, but it means going to your healthcare provider regularly to urine samples, regular testing for sexually transmitted infections, and some kidney assessments, like the blood test to make sure your kidney function stays fine. Post-exposure prophylaxis is the use of medications just in the short term if you think there was an exposure to HIV. So if someone thinks that they may have been exposed, maybe through sex, maybe through sharing needles or a needle stick, it's more of an urgent assessment to see if they can take medications to prevent HIV. So it has to be started within 3 days of an exposure. It's initiated at urgent cares or emergency rooms in the province. And it's a combination of 3 medications, usually 2 pills that are taken daily for a month. So again, different than PrEP is more of a like planned, non-urgent. I think maybe I'm at high risk and I can take medications every day to prevent infection versus oh, this is urgent, I might have been exposed, and just take medications for a month to prevent.
How long does the PrEP last?
So the PrEP lasts as long as someone still feels that they're at high risk for HIV. Maybe someone stopped injecting drugs or no longer has a partner or doesn't have multiple partners anymore. So some of that risk may change. So they may decide they want to stop PrEP. Otherwise, there's the opportunity to take it ongoing to prevent. For pregnant people, they should be offered testing for HIV to make sure we're aware of someone who's living with HIV who's pregnant. Also be tested for other sexually transmitted infections at their first prenatal and then also in every trimester to make sure we're aware of someone's HIV status in pregnancy. If someone is pregnant and living with HIV, their risk for transmitting mums to babies or excuse me, is very low with if you have access to all the interventions, all the different things we can do to decrease the risk. Without any interventions, the risk is about 25%, but that goes down to less than 1%. So those are things like being on antiretrovirals or HIV treatment during pregnancy, also during delivery, and then the infants receive medications for a month after they're born. Formula feeding can also decrease the risk. Sometimes a cesarean section may be considered, but usually isn't needed as part of a strategy to prevent transmission. And then the other thing that prevents HIV is for people living with HIV to be on treatment. So all people who've been diagnosed with HIV should be offered and able to start treatment as soon as possible. When people are on treatment and maintain a suppressed or undetectable viral load, they can't transmit HIV to sexual partners. So that's the, Lisa already mentioned, undetectable is untransmittable or used will be. Great question.
Because the focus here is on transition sexual partners, but what about injection drug users?
There just isn't as much scientific evidence. We don't know that the studies where you have partners where one person has HIV and one person doesn't were conclusive, and it's, you know, over 90% increased rates of transmission. We just don't have the same studies or science to know for sure that the risk is.
Is there any research for being pregnant and U equals U?
Yeah, so the question is there any research for being pregnant in U equals U? So that's about, you mean if you're
Do they
pregnant
have-
and you have HIV, you won't have HIV if you have an undetectable viral load.
Okay, so there's no extra precautions or medications that
We
baby
do-
has to take?
Yeah, we do extra things, make sure. So that's, if you're on HIV treatment and pregnant, the risk is very low, but we do additional things. I can't, know for sure, but maybe it's less than 2 or 3%, but we do those extra things by giving moms or during labor, giving treatment, and then also giving babies in case there was any bleeding or things around doses if you have an extended labor. So there's the potential that maybe there was a little bit of HIV in the blood, and that's why we also give babies kind of like a post-exposure prophylaxis. They also get 4 weeks of treatment just in case they were exposed during labor. Okay, so I'm going to switch gears a little bit and just talk a little bit about HIV care and treatment. So anyone that's diagnosed with HIV, referred for care and treatment, should have a baseline evaluation as soon as possible. That includes, asking people questions, getting blood work done, an exam, chest X-ray. Those are things are all done to assess the immune system, in particular that CD4 count, so we know how strong someone's immune system is, or if it's been weakened with HIV. It also will guide the need for medications to prevent infections that someone might be at risk for if their CD4 count's low. We also test for other sexually transmitted infections, check for tuberculosis or other illnesses, and the test will also help guide which treatment people might go on. Treatment is recommended for everyone as soon as possible after their diagnosis, and then the goal of treatment is to decrease the risk for infections, prolong life expectancy, and improve quality of life, suppress that HIV viral load, which will then allow the immune system to stay strong or to recover if it's been weakened a little bit. And then also that treatment is going to prevent transmission. When someone's on HIV treatment or in care, they usually follow up for blood work every 3 to 6 months.
When you talk about the other illnesses, you also test for COVID too at the same time.
COVID testing is usually just guided by symptoms. The question is if we're testing for other illnesses, do we always test for COVID? If you had symptoms when you're coming in for care of COVID, like a cough, we usually do that too. So yeah, we do monitor usually every 3 to 6 months, depending on how new to care or how stable people are. We always check the CD4 count and the viral load, and then offer screening for other infections, review how people are able to take pills every day. Sometimes that's difficult for some people. Offer vaccinations and screening to prevent vaccinations to prevent other infections, screening of other illnesses, and then offer allied services. So we're lucky to get 9 circles into the HIV program to be able to offer other services for people in care with counseling, health educators. We have programming, social workers, the things that might also be supportive for HIV. So when that we do that initial assessment, that probably that most important test that comes back is the CD4 count. So if it's so low, sometimes people need other medications, not just HIV treatment, to protect them against infections they might be exposed to in the environment. So a common one is known as PCP or PJP pneumonia. So if CD4 counts are low, less than 200, someone might have to be on a daily antibiotic dose. If counts are lower than 100, that also may need to be on a daily antibiotic. And sometimes some other infections, because their immune system's weakened, they might need to take other things as well, other treatments. But usually these medications can be stopped when people are then started on their HIV treatments. The CD4 counts are going to rise, and the HIV viral load becomes suppressed, and then some of those what we call prophylactic or defensive medications, those other antibiotics that people might be on, they can be stopped over time. So unfortunately, there's no cure for HIV, but it can be controlled with HIV treatment. HIV treatment is called antiretroviral therapy, or ART for short, and involves taking medicine daily. As I said, it will then reduce the amount of HIV in the body, which is called the viral load, to suppressed or undetectable levels. Sometimes people use all different kind of language. Some people say undetectable, controlled, asleep, suppressed. They all really mean the same thing. That HIV is suppressed. And it usually happens, sometimes I'll see as quickly if someone's on treatment, sometimes even after a month, we'll see already suppressed, but definitely within 3 to 6 months, if it's suppressed or undetectable on medication. Go ahead. Sarah.
So you hear in the news and stuff like that, somebody has HIV now, they have nothing. So is it just because it's undetectable or because it's not curable, right?
That's right. Yeah, so the question is HIV curable? And no, that sometimes we'll hear in the news that HIV was cured. There have been cases, but there are cases around where someone's had cancer and has needed a bone marrow transplant. So HIV, actually, this is a good slide to ask the question, because you can kind of see in the top picture where that red circle is, that's HIV binding to a CD4 cell. It needs actually a little co-receptor to get into the cell. So this gets complicated and I don't fully understand it, but when someone gets a bone marrow transplant, they could get potentially new CD4 cells or cells that don't have the co-receptor that HIV needs to get inside. So if this, gets a little bit, won't remember this totally clearly, but when HIV, your first infected with HIV, you have a certain co-receptor and it changes over time. That's what HIV is looking for to get into the cell. And then if someone's getting a bone marrow transplant, they can actually screen to see if that the HIV they have needs a certain receptor and try and find a donor that does not use it, that wouldn't have the receptor. So that's the news stories that I'm familiar with, where someone's being cured and maybe there's been in having cancer and going through a bone marrow transplant isn't reasonable. It's there's lots and lots of risks associated with it. We can so this just shows us in the life cycle how the drugs, the treatments work. So usually people will take 3 different medications that work at least in 2 different ways to treat HIV. So where I put the X's there, like common drugs either prevent the RNA from becoming DNA, or they prevent the DNA from integrating into the CD4 cell DNA, or they prevent it from making all the things it needs to make more HIV. So as it blocks the life cycle, the amount of HIV in the blood goes down to lower suppressed undetectable levels. And then once that happens, if CD4 counts were low, they'll increase over time once people are on treatment. Sometimes they've never declined if someone's diagnosed and put on treatment early, so this helps the CD4 counts stay high and the immune system stays strong. So HIV treatment has been around for a while, but when it first was developed with just one drug in 1987, AZT was the first antiretroviral drug. In 96 was when the science came up with combined therapy. It was called highly active antiretroviral therapy at the time, or HART, which was then this concept of using at least 3 different drugs to attack HIV at different spots in its life cycle. So now it's referred to as antiretroviral therapy, or HART. It is usually made up of 3 medications that work in 2 different ways. Today, we have combination pills with 2 to 3 medications in one, so both can take as little as 1 pill once a day. That's called a single tablet regimen. That's sort of the most common thing, where people only need one pill a day.
Has anybody ever asked you, when they first get tested and they go to you, has anybody ever asked you to go on a medication right away? Like,
When they're tested.
Yeah, well, after, yeah, and they're
Yeah,
positive and they go and
so
see
we do,
you.
I didn't put this in the top, but we do something, the question was about if we see someone that's newly diagnosed, do they want to go on medication right away? In these recommendations have changed over time. And we do something now called a rapid start or a quick start, because we know that's the best thing for people to get on medications right away. It's going to help the immune system stay strong and also prevents transmission to other people. So we try it as quickly as possible. So when people come in for their first blood work, that first baseline evaluation, there's certain reasons why sometimes we can't start. So we need to make sure people don't have tuberculosis or a brain infection or something that can actually get worse when you start treatment before it gets better. But usually, especially if someone had a question about sort of that timeline, knowing when someone was infected, if you had a recent negative test, you're feeling well and come in and for that basically try and start people on treatment right away. And then just, I think this is my final slide, that people do really well living with HIV treatment. Is highly effective if people are able to connect and be on medications, and life expectancy is really normal or near normal for people living with HIV, but does depend on other illnesses that people might have. Also, when they were diagnosed, if someone's diagnosed with a CD4 count that's low already, they might not have the same sort of prognosis. But those can do really well if provided the opportunity and supports for early diagnosis.
I've heard the term, medication holiday, like stop the medication for the,
But
you talk about that or what?
I kind of remember hearing about that too, but probably, so I started practicing in 2007, and when I started, there was still a thought that, and medications have changed a lot over the years too, so there was still a thought that the risks of medications need to be weighed out versus the benefits of being on treatment. And we would actually watch people's CD4 counts, so they might start at a normal level at over 500. We'd actually watch them drop to 350, and then treatment was recommended when they dropped to 350 to make sure the agent didn't further progress anymore. And because some of the older drugs were a lot more toxic, there was, I think that's where the concept of drug holidays came up, but it's not recommended anymore. Drugs are generally so well tolerated now that the risk is far outweighs the benefits. So I just adding at the end there too that it's really important to I think we get focused on treatment and just the pills, but there's a lot more to with the supports for living with any chronic disease. But we're again really fortunate to have a multidisciplinary team at where I work, and lots of allied supports, collaborators, and carers are really important to be able to improve access to care and outcomes and need. I just wanted to say thanks again for welcoming me and having me come and chat. I think we still have time for more questions. Go ahead.
Why do they call it chronic disease?
Chronic. So chronic is just a term that's the opposite of acute. And acute just usually means within a few weeks, whereas chronic just means it's longer. And because HIV can't be cured, it's chronic.
For people that who don't have doctors or don't like to go to doctors. If they're worried about being exposed, then they could go to a Winnipeg or a walk-in and get pepper prep. And that, or does it have, you have to have a
So-
doctor for that?
So PEP, the post-exposure
Yeah.
prophylaxis, the question is if you don't have a regular doctor, how do you get access to support like PrEP or PEP? So post-exposure prophylaxis, because it's urgent, is people need to go to an urgent care center or emergency department to get started right away. For 7, they always have the stock there. They can do the baseline testing and get people started right away. And then when you're there, people have the options of certain sites, including 9 Circles, clinics, some of the access centers around the center, or around the city where people can go for follow-up testing if they've been on post-exposure prophylaxis. PrEP or pre-exposure prophylaxis. We've been doing some primary care education to try and increase the access points where people can go and get PrEP. There is on our HIV program website a map so people could put in where they live, their address, and see where people are providing PrEP so that they could find someone in the area that they could the exposure prophylaxis. The other really useful map is on Street Connections. Street Connections can map online, shows you where you can get tested, where you can get supplies. I think they also now have links to where people can get stuff. Are there any other questions online?
No yet para mí. So, maybe not.
I didn't put in the, I was just gonna add, I didn't put in the presentation anything about disclosure. I wasn't sure if people had questions about that. That's about like, do I need to tell my sexual partner that I have HIV? And the sciences are a little bit different than what happens, what the legal answer is. If someone's undetectable, you can't transmit. But the recommendation is to use it, if you're not gonna disclose, to use a condom, even if you're undetectable. We know that. People have more questions about that.
So they have, like,
So
they have to disclose, even
So
though they're under.
yeah, it's because in Canada, we go by case law. So when a case goes through the court system up to the Supreme Court, that's what we say we follow. So that case years ago, what the ruling was that if you had an undetectable or a low viral load, so a low viral load is actually less than 1,500 copies, it's not actually undetectable. So if you had a low viral load and used a condom, you didn't have to disclose. But if you didn't meet both those things, maybe you do. So now there hasn't been another case that's gone up to the Supreme Court. So, but in provincial courts, cases where someone had an undetectable viral load and didn't disclose, they just get dropped because we know there was no real risk for transmission, but it's never gone all the way up. So I usually say to people that I know you can't transmit, and ideally you're able to disclose it through the condom. There's others that can consider.
I think it's fair to say Lori's gonna hang around for a few minutes.
Yeah.
If other questions come to mind as you're thinking.
Mhm.
Thanks a lot.